When your revenue keeps declining and your expenses keep going up, everybody asking for raises, your suppliers' costs are going up, invariably, you have to ask yourself, how do you stay viable? How do you thrive in this type of environment? Well, that was one of the questions asked in one of the physician Facebook groups recently, and there were no shortage of answers. So in this video, I'm going to go over some of those answers proposed by some of the physicians in that group. And keep in mind that this may not be urology specific. It may apply to primary care as well. So keep that in mind as we go through this, all right? Actually, I'm supposed to be somewhere else already, but due to flight cancellations, I'm still here. So I figured I might as well give you this information, do this brain dump. You are forewarned that this may be a little bit of a longer video, so you may want to play this back at 1.5x or 2x the speed, depending on your comfort level. Okay, here we go. Ways to deal with decreasing margins in private practice in light of inflation, decreasing payment from Medicare for the last 20 years, and all the expenses going up. So number one, eliminating bad payers. I know, we've talked about this before. It's scary to eliminate the insurance companies that are a lot more work for your staff, who pay you poorly. It's like a bad relationship. Why do you keep staying in that relationship? Why do you continue on that relationship, right? If you have someone that you don't get along with, it's time to cut the rope and move on. It's no different with a payer that constantly abuses their privilege, requesting data, requesting charts. You submit information to them and they keep losing that information. I say losing in air quotes. It's time to consult with your staff and ask, who are the problem payers for you? Who are the payers that delay payment to you and claw back unreasonably and require more work for your staff? Figure that out. Maybe look at them on a quarterly basis and eventually come up with, well, how big of a piece are they in your practice? Can you decrease exposure to that payer or eliminate exposure to that payer? Unfortunately, this is going to be data-driven. It has to be data-driven. So you are going to have to query your practice management software and communicate with your billing staff to get this type of information. Secondly, someone suggested a membership fee to have better access to your practice. Now, this may involve some legal ramifications and there may be payer restrictions. However, primary care doctors have been doing it. I think there's some specialty practices, specialists that are doing it. It gives the patients faster access, better access, and covers some of the services that you may charge extra for that we will discuss later on in this video. So charging a membership is something that was brought up among the answers. Number three, someone mentioned reducing your staff, and I added increasing automation. Cutting staff is always a little dicey. You may need the staff to handle your capacity, a volume of patients. Reducing staff, you may end up cutting off your nose to spite your face. You are probably, you have to look at your infrastructure, your patient volume to determine whether or not cutting that staff will decrease your bottom line, because that extra staff may increase net $10, $15, $20, $50,000 to your bottom line. Reducing staff will mean decreased capacity for you to make that production. So decreasing staff, even though they are the largest expense, but may not be the right thing to do. So you have to look at your entire operation to make sure that is the right thing to do. Increasing automation, I'm going to mention more about this later on. Increasing automations. There's something called robotic process automation that is coming to the fore. So look up RPA, Robotic Process Automation. You have all these disparate software systems. You got your practice management system that has to get information from insurance companies. Well, that interface, you have to create specialized APIs so that they could communicate. The cost is pretty high. Hurdle is pretty high to get that integration to happen. Enter RPA, Robotic Process Automation. It decreases hurdle to create that integration. Add on natural language processing, machine learning, artificial intelligence. It may make repetitive tasks, such as, in my mind, I'm thinking benefits authorization, benefits verification authorization, and determining co-pays and insurances. That type of repetitive task should be very easily subject to automation. Unfortunately, that is currently not happening for most of us, but I'm hoping RPA will help in the future. So look forward to that. That is coming, and I think larger organization may be a little bit further ahead in that automation process. And I bet the payers are using RPA to adjudicate our claims, to look at the stuff that we send to them so that they could train their AI, train their machine learning so that they can more accurately pinpoint appropriate and inappropriate billing. So stay tuned for that. Number 4, switching to in-person visits if telemedicine parity ends or payment for telemedicine decreases. I've started reading that some payers are decreasing, no longer covering telemed, number 1, or number 2, paying at a 50% of the regular in-person E&M levels. So if that particular line of business is not paying or not paying well, obviously switching to in-person visits. But then your in-person visits don't seem to be as efficient, and it requires a little bit more resource. So you got to think about whether or not you want to do that. You might want to consider charging for telemedicine visits as a value-add service that is not covered by insurance, so that it is a value add. It's something that you pay cash for. For me, for instance, if I have to go to the doctor, and I do have to go to many physicians, if I can do it via telemedicine, I would gladly pay out of pocket for my time, because the time to have to get in the car, to cancel clinic, to get in the car, to see the doctor, and then drive back, the risk that I would take on the road, right? And also with the current gas prices and also the loss in productivity, I would gladly pay for telemedicine. My time is much more valuable than the amount that I have to pay via telemedicine. So consider offering that. Don't think that because it's not covered by insurance that you should not offer it. So I'm going to pause here to welcome any questions in the comments. If you have any questions, if you're watching, a few of you are watching this live, or if you're watching this on a replay, feel free to ask any questions in the comments, and we'll try to answer those. All right, number 5, someone wrote, stop working for free, meaning making sure that you are charging and billing for everything that you do within reason. You have to understand what is included in the evaluation and management service that you provided if you saw the patient that day, and obviously the appropriate use of modifiers to signal to the payers that what you did is separate, in addition, significant and separately identifiable. So making sure that you are capturing everything that you do. Another thing that you can consider doing is chronic care management, primary care management. So these are all things that you should look into. If you're providing that service for free, you should make sure that you understand these rules, make sure what's available to you, and make sure that you are not working for free. Okay, option number 6. Someone mentioned go out of network. So before you go out of network, you have to really understand your demographic. You have to know what you're offering, and is this something that a practice can go out of network for? With the current No Surprises Act, if you are having to deal with the hospital or see patients or operate on patients in the hospital, that may greatly hamper your ability to get better payment by going out of network. A lot of the payments are, the discussion regarding out of network payment in that type of situation is still under legal scrutiny and debate. So stay tuned and keep up with what's happening with the No Surprises Act that came into effect January 1 of 2022. Before you go out of network, you have to make sure your marketing setup is extremely strong. Are you running a relationship-driven practice? If you're not, then patients are likely to leave once you go out of network. So always keep that in mind. You have to have a roadmap. You have to have a plan before you switch your practice to completely out of network. Or you can slowly, gradually move into out of network service. All right, number 7, someone said, so what? We're getting decreased reimbursement. Our costs are going up. Someone mentioned just write it out. Well, we've been doing that for 20 plus years. If you look at Medicare payments and if you take into account inflation, all the physicians have been getting decreasing payments from Medicare alone. So we've been taking it for 20 plus years. Do you really want to continue doing that? It's up to you. So number 8, someone mentioned switching to concierge medicine, membership fees for access. I think we talked about that earlier. Increasing access, and for the concierge medicine practices, they collect a membership fee, but then they also bill insurance. So by doing that, you have to keep in mind the type of clients or the type of patients that you are going to attract. Is this the type of patient that you want? I don't know. Maybe it is. Maybe not. Maybe you want to decrease your volume and maintain your revenue. This is one way to do it. And you can cap your membership numbers to X number of patients. And as long as you're happy with the production, you can do that. Number 9, optimizing electronic health record use and leverage technology. I already mentioned RPA up above, robotic process automation, optimizing EHR use. I can't stress that enough. EHRs, when you get it, it's just kind of like a blank slate. It is really up to all of us to tune it to the way you see patients and outsource everything that somebody else can do so that they can do it, and you the clinician, only do what you have to do, what you must do. EHRs can help automate that process, facilitate that process. You can set up protocols so you're not having to pick every single diagnosis, every single thing that you do for that prototypical patient for that particular diagnosis. It is much easier to bring down a templated process and then eliminate the things that don't apply to this particular patient. It is much easier to do that than to pick individual diagnosis codes, procedure codes, follow-up codes, labs that you're ordering, imaging that you're ordering. So keep that in mind. Leverage technology to your advantage to improve efficiency. Number 10, someone mentioned charging for forms. For instance, filling out disability forms, FMLA forms. Or some of the primary care docs say that they would do that as an appointment, as an in-person appointment with the patient in front of you. You fill out those forms. But you got to think in terms of, well, in 2021 E&M rules, is that really an efficient use of your time? Maybe you want to utilize an APP to help facilitate filling out those forms. But anyway, you should not be filling out those forms for free, because you are taking on liability. It is work, and your time is not free. So, and your staff time is not free. So you want to consider charging for filling out those types of forms. Of course, beware of state-related issues when you are charging for these forms. Think about the opportunity costs when you do these as an inpatient visit. So always keep that in mind. Number 11, somebody said sell products in your practice. For a lot of urology practices, that will be in-office dispensing. A primary care doctor who deals with endocrinology also sells CBD products. An optometrist said, or ophthalmologist says glasses, or optometrist, glasses. dry eye drops and products, vision aids, IPL lasers, masks. Someone said, hey, if you forget your mask, we're going to charge you for it. So a lot of different things that you can do to sell products and generate additional revenue. All right, suggestion number 12, charge an invoice or billing fee if the patient does not pay at the time of service or after the first invoice. Obviously, you want to have that in your financial policy when the patient first encounters your practice, but certainly charging for an invoice, billing fee is reasonable because it does take your staff time to chase after the balance. If the patient chooses not to pay at the time of service, you can consider charging an invoice fee or a billing fee. I know some practices are doing that. Number 13, that ties in with number 12. You want to collect patient responsibility at the time of service. Some have suggested a check-in, not a checkout or later, but a check-in. And what does that mean? You want to collect all co-pays, co-insurance, unmet deductible at the time of service at check-in. I can't stress this enough. This is a huge bucket of your revenue. And if you're not collecting that, you're actually in breach of contract with your third-party payer, with your insurance company. The patient has a contractual obligation with the insurance company to pay for the copay, co-insurance, and deductible. And you, as the qualified health professional, have a contractual obligation with the insurance company to collect that as well. By you not doing that, you are in breach of your contract. I have heard of practices whose payments are decreased because their payment is now determined at the rate, the new rate, less the copay, because the insurance company got wind that you are not collecting copay, so they determine your fee schedule at that less copay amount, decreased copay amount. So don't suffer that fate. Make sure you are collecting all patient responsibility at the time of service. Number 14, credit card on file, keeping a credit card on file for all patients. So you're not chasing after the dollar. You can set up a financial policy at the very beginning of the visit. First encounter, saying that we're keeping your credit card on file in a secure manner. You have to make sure your infrastructure is there. You can't write down the credit card number and store it in a drawer. That is not secure. You definitely do not want to do that. So make sure you have everything set up to capture that information securely. You want to do that for all patients. Let them know that for a balance under a certain amount that is due the practice, you are automatically going to charge that on the credit card on file, so you're not chasing after the balance. All right. Number 15, increasing your fees for cash services. So increasing your rates. Obviously, this is not for insurance companies. I guess you can certainly negotiate a different rate with the insurance company, but for those cash services that you offer, you can consider charging more for those services, increasing your rates. All right, number 16, charging for medical records. All right, so this is also subject to state limitations and rules in terms of insurance. As those of you in the Thriving Urology Practice Facebook group know, some of the risk adjustment records requests are not covered. And some of you have collected tens of thousands of dollars for these medical records requests from insurance companies. So you are able to charge, and you can charge, and you should charge when appropriate. But keep in mind, when patients ask for that information, you do not want to run afoul of information blocking, which is a federal mandate. You do not want to inappropriately withhold information from the patient. So know about HIPAA. All right. Know about HIPAA, know about information blocking. Make sure you're not violating information blocking. Okay, number 17. Make sure you are capturing all payments due from payers. Someone suggested that you pour over all EOBs. And that is something that your billing staff can do if you have one of those. If you outsource your billing staff, I hope they are going after those denied claims. And for the outsourced billing services, the low-hanging fruit is that first time that when they send the claim through and they get paid, that is the easiest money for them, for the third-party billing company. Whenever they have to rework a claim, rework a rejection, the amount that they would gain is typically not really worth their time from an efficiency perspective. So you always have to keep in mind their financial incentives and making sure that you are not losing any rejected claims. Make sure those claims are not written off automatically by your biller, coder, by your third-party payer. So that requires a little bit of auditing on your part and making sure somebody is looking over those EOBs and write-offs. Number 18, fight for every unpaid claim or bill from the payer and the patient. That's pretty common sense. You've already provided a service. You want to go over the EOBs after the claim's been adjudicated. You want to make sure that you are getting everything that is due you and not writing things off. So some of these overlap. Number 19, charging for prior auths or having an office visit, have the patient come in for office visits for prior auths. Notorious medication prior authorizations. You all know about this. Someone mentioned using Cover My Meds during the office visit to go through the prior authorization. Some primary cares have called the authorization entity while the patient's in the office and doing that during the office visit. So keep that in mind. Opportunity cost for that physician or qualified health professional. Can you outsource this? Maybe done by an ancillary staff. So keep that in mind. Office visit, physical in-person office visit slots are very valuable to the practice and to the patient. So keep in mind the opportunity cost when you do that with the patient in front of you. All right, number 20. Someone said, bill for literally every breath you take. And this goes back to making sure that you are charging for the things that are appropriate. This person charges phone calls, audio-only calls. During the public health emergency, there are codes that you can use for audio-only codes, audio-only visits. Make sure that you know what's included and what is not included, what you can and cannot bill for that particular audio-only visit. This person also wrote any non-face-to-face work that she can charge, she's going to charge for it. Records review. Those of you who are in the Thriving Urology Practice Facebook group know about 99358. Make sure you know about that code, how to appropriately document, and how to appropriately use that code. Talking to other physicians. So that is something else that you can bill for. There are G codes that you can use to code for interprofessional consultation. Again, there are caveats, there are rules, and the payment is pretty minuscule, but there are codes that you can use to bill for that interprofessional consultation. Know about what's included in evaluation and management. Some of the voice or audio-only calls, you have to make sure that is not included in the E&M of a prior visit. So again, knowing the rules of the game. All right, suggestion number 21, limit drug rep and equipment rep access unless their products and services are being used by you. Somebody suggested, my time is so valuable that I don't want to see reps unless I am utilizing their products. Well, that kind of limits you because you won't learn about something new on the horizon if some of these reps don't come to see you. Sometimes you read about it in professional journals, but some of the equipment you kind of have to see, you kind of have to feel, and you can't really get it from reading the back of a magazine or an ad. Obviously, you can always go to YouTube. Unfortunately, sometimes even some of the newer technology, YouTube information is limited Professional groups like the Thriving Urology Practice Facebook group obviously is another resource, but limiting equipment rep access may or may not work for you. It just depends on your practice and your situation. All right. Suggestion number 22, credit cards. I've done multiple videos on credit cards, credit card merchant fees. You want to make sure you negotiate better credit card merchant fees. This is a lot of money. Even for a small single provider practice, a urology practice, this is in a 5-figure range because everybody is using credit cards in your practice. And your credit card merchant fees, your credit card processor is charging at least 2%. So you're taking a 2% haircut of whatever's already a reduced payment from the insurance company, and you're taking a 2% payment decrease from the person using the credit card. And of course, you never accept a virtual credit card from an insurance company. So if you're not doing that, if your coding and billing staff, your posting staff is accepting virtual credit cards, please tell them to stop. All right. You also want to look at, evaluate, and understand your merchant statements. Is your staff capturing the CVV, the security code, the billing zip code? Because when you capture that type of information and you're manually putting in the number to bill on that credit card, you're actually decreasing the cost to you, the practice, whenever you enter that information and you don't have the card in front of you and you're using that to charge the patient. The more information that is appropriate that you capture, the less the cost to you as the practice. Obviously, if you can, minimize having that charge when the card is not present. So when the patient calls on the phone and your staff is writing down the numbers and then putting that in manually, that is the most expensive form, other than virtual credit cards. That is the most expensive form of payment to your practice. So you want to keep that in mind, and make sure you minimize those charges. And obviously, always be looking at credit card merchant surcharges. Sometimes if you're not compliant with some of the security standards for the credit card companies, you are incurring a monthly charge by not being PCI compliant. So make sure you're not getting charged unnecessarily. All right, number 23. I already mentioned it. Do not accept virtual credit cards from payers. They've gotten pretty smart, pretty sneaky. They say, hey, here's your payment for the claims that you submitted in the form of a virtual credit card. They may fax it to you, and here's the credit card number. Well, they're partnering with these credit card vendors, and they're getting a kickback. So not only are you taking a discount from the insurance companies, you're taking a further discount from the merchant processor when the insurance company pays you with a virtual credit card, and they're getting a little kickback from using that virtual credit card. So never, ever accept virtual credit cards from the payers. All right, number 24. Charging for no-shows and last-minute cancellations for appointments, procedures, and surgeries. That's an opportunity cost. There's a shortage of physicians and especially urologists. So no-shows, last-minute cancellations cost the practice. And believe it or not, you can bill for no-shows, for last-minute cancellations, as long as you uniformly apply that to all your Medicare patients. It is legitimate, it is legal, and that's been the case for many, many years. And you want to make sure you apply this equally to all your payers, and including Medicare patients. So that's, even though it doesn't recoup, you're not going to be made whole by charging these no-shows. It sends a signal that you value your time, and having these no-shows and last-minute cancellations without reason is frowned upon and is not commonly accepted by your practice. Now, obviously, if you're going to do that, you should try to run on time as much as possible, because you should value the patient's time. as much as you value your time. All right. Number 25, basically joining in a group, joining physician consortiums, forming groups, clinically integrated networks, accountable care organizations to help negotiate better rates. Some of the urology and specialty groups have already consolidated, formed these private equity ventures where they have a mothership of a group and then a bunch of other smaller practices coming underneath it. So it gives them leverage. It gives them negotiating power with the payers, also hopefully better rates from the different vendors. All right, number 26, almost done. You want to engage with your government representative to change the rules legislatively instead of just fighting these little battles. You want to start from the top down. And I highly encourage everyone join AACU organizations for urologists such as American Association of Clinical Urologists, American Urologic Association, and also Large Urology Group Professional Association, LUGPA. LUGPA is actually really, really smart. Instead of just throwing money for the short term, they strive to form long-term relationships with representatives from both sides of the aisle. And they will interact with them when the times are good and also when the times are bad. So obviously you don't want to just go to the legislators when the times are bad. They want to foster that long-term relationship so that when the time comes to press urgent agendas, they will have already formed that relationship and can push through more favorable agendas in the legislature from the Hill. All right, number 27. Somebody suggested physicians collectively stop taking insurance. Well, unfortunately, physicians, and we're kind of an eclectic group. We all have our own independent ideas of what is the best way of doing things. And getting physicians together to agree on a large agenda, that's kind of tough. And I think that is our downfall. Physicians, we can't collectively get together and say, this is what we're going to do. And that's why we get pushed around. And that's why we are in our current situation. So physicians collectively stop taking insurance. Unlikely to happen, but it was suggested. Number 28, direct primary care or direct specialty care. These are practices. You can look up DPC, you can look up DSC. These are practices that do not participate in any sort of insurance. They take a membership fee and they give access to their members. So very popular among primary care. I'm not sure of any direct specialty care practices in urology, but that will be something that I'm interested in looking into. So if you know of any direct specialty practices in urology, let me know. Number 29, someone mentioned outsourcing billing. Well, always be cautious. I know there are successful practices who have outsourced their billing, but if you look at MGMA, Medical Group Management Association's reporting and their surveys, they will tell you better performing practices do their billing in-house for many, many reasons. So take that with a grain of salt when it comes to outsourcing billing. I personally prefer in-house billing for many reasons. Do what works for you, obviously, because there are advantages and disadvantages of in-house versus outsourced billing. Lastly, one of my favorites is number 30. You want to maximize what is due you as a qualified health professional through appropriate coding and billing, the use of modifiers, and for some of the primary care doctors, the appropriate use and reporting of RAF scores for those primary care doctors, risk adjustment factor scores. So understanding the rules of the game. Evaluation and Management 2021, that's been going on for over a year now. Make sure you understand those rules. For those of you who are proceduralists, make sure you understand the use of modifiers in addition to the E&M rules. Make sure you understand global periods, what is included and what is not included in a global period, when you can and when you cannot bill for certain services. If you understand these rules, I've been talking about this ad nauseum in the Thriving Urology Practice Facebook group. If you understand these rules, it is almost fun to play this game. These rules are given to us from HHS, Health and Human Services, CMS, AMA, the CPT panel. Once you learn it, you're going to use it for the rest of your practice career. And what better way to make sure that you are capturing everything that is due you by learning about these rules? Just like the tax code I said before, just like the tax code, you're using that to your advantage. This is no different. You're using these billing and coding codes to your advantage in a legal and ethical fashion. Nothing wrong with doing it, but make sure you understand the rules. Make sure you're not leaving any money on the table. So, as always, I appreciate your comments, and I'm seeing no comments here. So, thank you very much for the privilege of your time. Whew, it's been a long one. This is a long one. And please take care of yourself and take care of each other. Have a good one. Bye-bye.